I want you to try something right now, assuming you aren't driving or operating heavy machinery.
Yeah, definitely don't try this if you're behind the wheel.
Right, safety first. But if you're just sitting there, I want you to take a normal breath in and hold it.
And just keep holding it while we talk.
Exactly. Within a few seconds, you're going to feel this rising, undeniable panic in your chest. It's like this itch that turns into a burning, just overwhelming demand to exhale.
Most people assume that burning sensation is your body starving for oxygen.
Right. I always thought that. But it isn't, is it?
No, not at all. Your blood actually has plenty of oxygen to last for a couple of minutes.
So what is that panic then? Because it feels pretty real.
It's actually your brain sensing that your blood is becoming ever so slightly more acidic because carbon dioxide is backing up in your system.
Wow. Okay, you can go ahead and exhale now, by the way. I don't want anyone passing out.
Yeah, please exhale.
No.
But it's an incredibly sensitive alarm system. The human brain constantly monitors the acidity of the blood down to a fraction of a percent.
And the moment that pH shifts, it basically triggers a survival cascade.
Exactly.
So that invisible, continuous background process, the swapping of gases that keeps that alarm from ringing, that is exactly what we are looking at today. Welcome to the deep dive.
We're venturing into a really profound and honestly sometimes incredibly fragile piece of human machinery.
We really are. I mean, we take about 20,000 breaths a day, completely on autopilot. You don't even think about it.
But when that invisible exchange is interrupted, whether it's by a microscopic virus or a physical mechanical collapse, it just creates sheer physiological chaos.
Which is wild. So today, we're basically going to examine this through the lens of medical detectives, right?
That's the mission. We need to understand the perfect baseline physics of the lungs first. Like what happens when everything is working seamlessly?
Right, because you can't understand the broken machinery until you know how it's supposed to work.
Exactly. And then we can deconstruct what exactly happens when diseases like asthma or COPD hijack that system.
And more importantly, we'll look at how medical professionals actually troubleshoot a failing airway when the clock is ticking, which is honestly terrifying to think about.
It's intense.
So to even begin to understand the diseases, we have to look at what you call the holy trinity of gas exchange.
Right, the three absolute pillars that have to work in perfect harmony: ventilation, diffusion, and perfusion.
If any one of these fails, the whole system just crashes.
It completely crashes.
Let's start with the mechanical side. So ventilation. I feel like people often confuse ventilation with respiration, but ventilation is purely physical.
Purely physical, yes. It is literally just the mechanical movement of air in and out of the lungs, and it relies entirely on pressure gradients.
Okay, so how does that actually work in the body?
Well, below your lungs sits the diaphragm. It's this massive dome-shaped sheet of muscle.
Right.
When your brainstem sends the signal to inhale, that dome contracts and flattens downward. And at the exact same time, the muscles between your ribs pull your rib cage out.
Which drastically increases the volume of your chest cavity.
Exactly.
And thanks to basic physics, I think it's Boyle's law, right?
Yeah, Boyle's law.
So if you increase the volume of a container, the pressure drops.
You've got it. You basically create a negative pressure vacuum inside the chest.
Okay, so the pressure inside your lungs becomes lower than the atmospheric pressure outside your body.
Right. And because of that, air just simply rushes in to fill the void.
Oh, that makes so much sense. It's not like you're sucking the air in, it's just physics pushing it in.
Exactly. And then to exhale, the diaphragm just relaxes. It curves back up into that dome shape, the chest cavity shrinks, the pressure inside goes up, and the air is forced back out.
Okay, so I like to think of this like a shipping logistics center. Ventilation is just opening the warehouse doors and letting the goods inside. The air is in the building.
I like that analogy. So the goods are inside. That brings us to the second pillar, which is diffusion.
And this is where the air actually meets the blood, right?
Right. This takes place in the alveoli.
The what? Alveoli.
Yeah. Alveoli, yeah. If you trace the airway down from the windpipe, it branches into smaller and smaller tubes.
Like a tree.
Exactly like an upside-down tree.
Yeah.
And it eventually ends in millions of these microscopic, highly permeable air sacs.
And what do they look like?
They look somewhat like tightly clustered bunches of grapes.
Okay, so in my head, I just picture these as tiny wet balloons.
That's essentially what they are.
But wait, if they were just wet balloons, wouldn't the moisture on the inside walls make them stick together? Like, wouldn't they just collapse the second we exhaled?
That is actually a massive fundamental physiological problem. It's governed by something called Laplace's law.
Okay, another law of physics.
Yep. Water molecules love to stick to each other. So if the inside of the alveolus were just coated in regular water, the surface tension would be so high that the sac would collapse instantly.
Wow.
And you would literally never be strong enough to pull it back open with a normal breath.
That sounds terrifying. So how do we not just suffocate immediately?
That is why the body produces a highly specialized substance called surfactant.
Surfactant. So it's kind of like a biological detergent.
It functions exactly like a detergent, yeah. It's this complex mix of lipids and proteins that breaks up that surface tension.
Oh, wow.
So it keeps the alveoli propped open, pliable, and basically ready for gas exchange.
I've heard that premature babies sometimes have trouble breathing. Is that related to this?
It's entirely related to this. Premature babies often struggle to breathe precisely because their lungs haven't started manufacturing surfactant yet.
Oh, that's heartbreaking, but it makes total mechanical sense. So, assuming we have surfactant keeping our warehouse loading docks open, the actual diffusion is it's just gases moving down a concentration gradient, right?
Exactly. We breathe in air that is really high in oxygen, and the blood flowing past the alveoli is low in oxygen.
Because it's coming back from the rest of the body?
Right. So the oxygen passively drops across this incredibly thin, literally one cell thick membrane into the bloodstream.
And the carbon dioxide does the exact opposite. It's highly concentrated in the returning blood, so it hops over into the alveoli to be exhaled.
That is the swap. And that brings us to the third pillar, which is perfusion.
Okay, so we had ventilation, diffusion, and now perfusion.
Right. You've brought the oxygen into the lungs with ventilation. You've swapped it into the blood with diffusion. Perfusion is the cardiovascular system's ability to actually pump that newly oxygenated blood out to the farthest reaches of your body.
And then bring the waste products back.
Exactly.
Okay, so if we stick with my logistics analogy, perfusion is basically the fleet of trucks driving down the highway to deliver the goods to the cellular stores.
I love the truck analogy because it works perfectly for the blood. The oxygen doesn't just float freely in the blood, it needs a transport vehicle.
Right, which is the hemoglobin protein inside our red blood cells.
Yes. Hemoglobin is just this beautifully complex molecule. Each hemoglobin protein has 4 binding sites, so 4 seats in the truck, so to speak.
And those seats are made of iron, right?
They are made of iron. Oxygen binds tightly to that iron. And without adequate hemoglobin, it honestly doesn't matter how well your lungs work.
Really?
Yeah, you simply cannot transport enough oxygen to keep the tissues alive if you don't have the trucks.
Wow, so that explains why anemia makes people so exhausted and short of breath. They just don't have the transport capacity.
Exactly. For context, normal hemoglobin levels hover around 12 to 16 grams per deciliter for women and 14 to 18 for men.
So if you drop down to like an 8, half your fleet of delivery trucks is basically off the road.
Precisely.
But this introduces a really wild concept that I definitely want to unpack here. If my hemoglobin is completely fine and I'm taking massive deep breaths, meaning my ventilation is perfect, can I still suffocate?
You absolutely can.
Wait, really? How?
It all comes down to a physiological principle known as ventilation perfusion matching, or VQ matching for short.
VQ matching.
Okay.
The air and the blood have to arrive at the exact same location at the exact same time. The goods have to physically meet the trucks at the loading dock.
Exactly. If you have perfect ventilation, so air is pouring into the alveoli, but let's say you have a blood clot in a pulmonary artery.
Oh, pulmonary embolism.
Right. That clot is blocking the blood flow to that specific area of the lung. So you have what we call wasted ventilation or dead space.
So you have perfectly good oxygen just sitting in an alveolus,
Yeah.
but no blood is arriving to pick it up.
Exactly. And it works in reverse, too.
Oh, interesting. How so?
Let's say the heart is pumping perfectly, the blood is flowing smoothly to the lungs, but you have a disease like pneumonia.
Which fills the alveoli with fluid.
Right, so the blood rolls past, but no oxygen can get through that fluid to actually reach the blood.
So the trucks arrive at the loading dock, but the doors are jammed shut.
That is called a shunt. Blood moving past the lungs without picking up air.
Yeah.
The entire system requires near-perfect synchronicity to work.
Okay, so what happens when that synchronicity fails? Like, how does the body react when the tissues finally realize the oxygen delivery has completely stopped?
Well, hypoxia is the medical term for this. It literally means low oxygen in the tissues.
And untreated, that kills cells, it kills organs, and eventually it triggers fatal cardiac arrhythmias, right?
It does. But let's establish the baseline of a healthy patient first so we know what we're looking at.
Good idea.
A normal respiratory rate is 12 to 20 breaths per minute. Your oxygen saturation, which we measure with a pulse oximeter, should be 95% or greater.
Okay.
The patient's skin is appropriately colored, and cognitively, they are completely alert and oriented.
But when that oxygen level drops, the alarm bells start ringing. And this is where my mental model of this whole thing was just totally wrong.
How so?
Well, we always see it in movies, right?
Yeah.
Someone is suffocating, their hands go to their throat, and their face immediately turns this deep, dramatic blue.
Yeah. You were talking about cyanosis, that bluish discoloration of the skin, the lips, or the nail beds.
Right. Is that not what happens?
I mean, it happens, but relying on that visual is a really dangerous clinical trap. Cyanosis is a very, very late sign of hypoxia.
Oh, really?
Yeah. By the time a patient's fingertips are actually turning blue, they are already deep, deep into a metabolic crisis.
Oh, wow. So if blue is a late sign, what is the early sign? Like if I'm trying to catch a failing airway before it's too late, what am I actually looking for?
The absolute earliest, most critical sign is neurological.
Neurological, not respiratory.
Nope. It is profound, unexplained restlessness, usually paired with anxiety and tachycardia, which is an increased heart rate.
I really want to pause on this because it's just fascinating to me. Why is the brain the very first thing to react rather than the lungs or the heart?
It's because the brain is the most metabolically greedy organ in the human body.
Greedy. I like that.
It consumes a massive, disproportionate share of your oxygen. So the moment the oxygen saturation in the blood dips, even slightly, the brain senses starvation.
It's like the canary in the coal mine.
Exactly. It interprets this drop in O2 as an immediate life-threatening emergency. It triggers the amygdala and the sympathetic nervous system, essentially flooding the entire body with adrenaline.
It's a survival alarm. The brain is just screaming, "We are dying! Move! Do something! Find air!"
And physically, that manifests as a patient who suddenly just cannot sit still. They feel an impending sense of doom.
Which has to be terrifying.
It is. And their heart rate skyrockets to 120 beats per minute because the body is desperately trying to circulate whatever limited oxygen is left much, much faster.
Think about how easily this gets misdiagnosed in the real world. Like, imagine an 80-year-old patient recovering from surgery.
Right.
And suddenly they start picking at their bed sheets or trying to climb out of bed, snapping at their family, acting totally confused. The immediate assumption from a tired caregiver might just be, oh, they're having a delirious episode, or they're just being difficult.
Or they might mistakenly assume it's just a bad reaction to pain medication.
Exactly.
But in reality, their brain is literally suffocating. In medical diagnostics, an acute change in mental status, especially sudden restlessness, demands an immediate check of their oxygen levels.
That's such a good rule of thumb.
You never assume confusion is just confusion. It is hypoxia until proven otherwise.
Okay, so the alarm bell is ringing, the brain is restless. Let's start looking at the specific intruders that can trigger this cascade.
The diseases.
Right. The first one we need to dissect is asthma. Asthma is classified as an episodic, hyperresponsive airway disease, right?
Episodic is definitely a key word there. An asthmatic patient actually has perfectly normal lung tissue between attacks.
Really? So the lungs aren't permanently damaged?
Generally, no. The problem is an extreme, totally unwarranted immune reaction to a trigger.
And a trigger could be like a classic allergen like pet dander or pollen, right?
Yes, but it can also be freezing cold air, intense exercise, or even certain chemicals like NSAIDs or MSG.
So when that trigger enters the airway, it sets off this three-pronged attack that completely compromises the physical space available for air.
Let's break down those three prongs. The first prong is acute inflammation. The lining of the airway actually swells up.
Which narrows the tube.
Right. The second prong is excessive mucus production. The goblet cells in the respiratory tract go into absolute overdrive.
And lung cells.
Yeah, they secrete thick, sticky mucus that clogs the lumen, which is the opening of the airway.
Okay, so we've got swelling and we've got mud. What's the third prong?
The third prong, which is arguably the most immediate mechanical threat, is bronchoconstriction.
Bronchoconstriction. So the airways are squeezing shut.
Exactly. The airways in our lungs are wrapped in bands of smooth muscle. Now, we don't consciously control this muscle.
Right, I can't just flex my lungs.
Exactly. In an asthma attack, the chemical signals from the immune response command those smooth muscles to violently contract and spasm.
Okay, so going back to our warehouse analogy, the hinges on the doors are swollen from the inflammation, the floor is flooded with thick mud from the mucus, and someone is physically squeezing the door frame shut from the outside with those muscles.
That is a perfect visualization. The physical space for ventilation practically disappears, Air gets trapped inside, oxygen levels plummet, and carbon dioxide builds up.
So, to reverse this, we rely on inhaled medications.
Yeah.
And understanding the pharmacology here is crucial, right? Because we use two completely different classes of drugs to solve two different parts of that three-pronged attack.
Yes, and getting them confused is very dangerous. The frontline rescue drug is a bronchodilator, most commonly albuterol.
Let's talk about albuterol. If the swollen airway is a barricaded door, albuterol is essentially the battering ram.
I like that. It is a short-acting, incredibly aggressive medication. You inhale it, and within literally 1 to 5 minutes, it forces those spasming, smooth muscles to relax.
So it just kicks the door open. How does it do that chemically?
It acts on specific receptors, beta-2 adrenergic receptors, which are located in the lungs. When albuterol hits those receptors, it chemically commands the muscle bands to let go.
But the battering ram doesn't do anything about the actual swelling or the mucus, right? It just forces the muscle pathway open.
Correct. For the inflammation, you need the second medication, which is an inhaled corticosteroid.
So I conceptualize the steroid as kind of the long-term maintenance crew. It's not really meant for an emergency, is it?
No, not for an acute attack. It works by quietly suppressing the immune system locally in the lungs, basically turning off the fire alarm so the swelling goes down over time.
And that leads to a fundamental rule in respiratory pharmacology that everyone should know. If a patient is wheezing and gasping for air, and they have both an albuterol inhaler and a steroid inhaler on their nightstand, which one do they use first?
It absolutely has to be the albuterol, always.
Always. Why is that so strict?
Because if you inhale the steroid first, the airway is still clamped completely shut by those muscle spasms. The steroid particles will literally just hit the back of the throat and stop.
Oh, so the medicine never even reaches the lungs.
Exactly.
Yeah.
You must use the bronchodilator first to mechanically open the pathway, wait a few minutes, and then use the steroid so the medication can actually descend deep into the lung tissue.
It makes perfect mechanical sense when you explain it like that. But using albuterol is essentially inducing a massive sympathetic nervous system response, isn't it? It has to have collateral damage.
It definitely does. I mentioned earlier that albuterol targets beta-2 receptors in the lungs. But the human body isn't perfectly compartmentalized.
Right.
The heart is actually covered in beta-1 receptors. And albuterol isn't a perfect sniper. It has some cross-reactivity. So when you take a large dose of albuterol, it also stimulates the heart,
Tachycardia. The heart rate just shoots up.
often well over 100 or even 120 beats per minute.
Wow.
Yeah, so if you have a patient whose heart is already racing because they are terrified and hypoxic, giving them albuterol is going to push that heart rate even higher.
It creates a crazy clinical tightrope.
Yeah.
You have to save the airway, but you are drastically increasing the workload on the heart.
You fix the lungs, but you strain the pump. And it also causes severe skeletal muscle tremors. Patients get incredibly jittery.
Right. Their hands shake like they've just had 10 cups of espresso.
Exactly. Now, the tremors are uncomfortable but benign. The tachycardia is the vital sign you must actively monitor.
Now, the steroid inhalers have their own strange side effects too, don't they?
They do. Because they are suppressing the immune system in the mouth and throat, they actually wipe out the good bacteria that usually keep things in balance there.
Which allows opportunistic infections to take root, like fungal infections.
Yes, specifically fungal infections. An inhaled steroid can very easily cause oral thrush. That's an overgrowth of yeast that forms painful, white, almost cottage cheese-like sores inside the mouth and on the tongue.
Yikes. But the fix for that seems almost laughably low-tech compared to the pharmacology.
Yeah.
You basically just tell the patient to swish their mouth out with tap water and spit after every single time they use the steroid.
Literally just physically wash the residue off the mucous membranes. It is entirely preventable with basic oral hygiene.
But actually delivering these medications into the lungs is a mechanical challenge of its own. I mean, using a meter-dose inhaler requires a surprising amount of coordination.
It's notoriously difficult for a lot of patients. It's not like spraying breath spray.
Right. You have to exhale completely, press the canister, and then inhale slowly and deeply at the exact same millisecond.
And if you do it wrong, the medicine just blasts against the roof of your mouth and does nothing.
And even if you do it perfectly, you have to follow what's called the rule of tens, right?
Yes, the rule of tens. Once you inhale the medication, you must hold your breath for 10 seconds.
Why 10 seconds?
Because if you immediately exhale, the microscopic particles of the drug just stay suspended in the air and get blown right back out into the room. Holding your breath allows those particles to actually succumb to gravity and settle deeply onto the mucosal lining of the bronchioles.
That is so interesting. But what about people who just can't coordinate the spray and the breath? Like a 5-year-old or maybe an elderly patient with arthritis?
For them, we use an aerochamber, or what's commonly called a spacer. It's a plastic tube that attaches to the mouthpiece of the inhaler.
So you spray the medicine into the tube instead of directly into the mouth.
Right. It creates a little suspended cloud of medication inside the chamber, and then the patient can take 2 or 3 slow, normal, deep breaths to pull it all in.
It basically separates the actuation from the inhalation.
Exactly. Dramatically improving how much drug actually reaches the lungs.
Okay, so asthma is an episodic, reversible event. You trigger a spasm, you use a drug to break the spasm, and the airway goes back to normal. But I really want to pivot to a much darker reality.
Oh, COPD.
Yes. What happens when the structural damage to the lung architecture is permanent, progressive, and completely irreversible?
Right. We are talking about chronic obstructive pulmonary disease, universally known as COPD.
It is one of the leading causes of death worldwide.
It is. And the vast majority of cases are driven by decades of smoking, or in some cases, severe environmental exposure to pollutants.
But COPD isn't really just one disease, is it? It's kind of a clinical umbrella term for 2 distinct, simultaneously occurring nightmares: emphysema and chronic bronchitis.
Exactly. Let's break down the physical destruction of emphysema first. Emphysema is the actual destruction of the alveoli.
The little air sacs.
Right. The chemical toxins in cigarette smoke trigger chronic, long-term inflammation. And this inflammation releases enzymes that literally digest the elastin in the lungs.
Elastin. So the stretchiness. Remember those beautiful, tight, elastic clusters of grape-like alveoli we talked about?
The ones that easily snap back when we exhale?
Yeah.
Yes. Emphysema destroys the walls between them. The grapes literally merge into these massive, distorted, floppy bags.
That sounds awful.
You lose a staggering amount of surface area inside the lungs, meaning the physical real estate available for oxygen to diffuse into the blood just plummets.
And because you've destroyed the elastin, the lungs completely lose their recoil. They become like a stretched out rubber band that just won't snap back anymore.
Exactly. A healthy exhalation is mostly passive. You just relax the diaphragm, the lungs snap back, and the air is naturally pushed out. In emphysema, there is no snap.
So the air goes in, but it can't easily get out.
It becomes permanently trapped inside those floppy, destroyed air sacs.
And this permanent hyperinflation literally physically distorts the human body, doesn't it? The lungs get so permanently huge from the trapped air that they push the diaphragm completely flat.
Yes, it can no longer curve up into its normal dome shape. And a flat diaphragm is at a massive mechanical disadvantage. It simply can't pull down effectively to generate the negative pressure needed for the next breath.
And then, layered on top of all that structural failure, you have the chronic bronchitis part.
Right. The airways leading down to those destroyed alveoli are constantly, chronically inflamed, and the body is just pumping out a continuous stream of thick, purulent mucus.
It is a horrific combination.
Yeah.
The airways are blocked with mucus, and the alveoli at the end of them are destroyed and just trapping air.
The physical presentation of an advanced COPD patient is honestly impossible to forget once you understand the mechanics driving it.
Walk us through what that looks like.
Well, they often have very thin arms and legs, not necessarily because they don't eat, but because the physical act of trying to force air out of broken lungs burns an unbelievable amount of calories.
They're literally working out just by breathing.
Exactly. Their accessory muscles, so their neck and shoulders, are doing the heavy lifting that the diaphragm used to do.
And they develop what's called a barrel chest, right?
They do. The chronic trapping of air literally forces the rib cage outward over years and years, making their chest as deep from front to back as it is from side to side.
That's wild. And they usually have clubbed fingernails too, don't they?
Clubbing is a really fascinating physiological adaptation. The tips of the fingers become enlarged, and the fingernail curves drastically over the top, looking almost like an upside-down spoon.
What causes that?
It is driven by chronic hypoxia. When the peripheral tissues are starved for oxygen over years, the body actually releases growth factors to try to build new capillaries in the nail beds, which physically alters the shape of the bone in the nail over time.
It's amazing how the body tries to adapt. You will also frequently see a COPD patient sitting in what's called the tripod position.
Yes, very common. They sit on the edge of a bed or a chair, lean forward, and plant their hands or elbows firmly on their knees.
They are basically using geometry to survive, aren't they? By anchoring their arms, they stabilize their shoulder girdle.
Exactly. This allows them to use their pectorals and neck muscles to literally wrench their rib cage open to pull air in.
And when they exhale, they do something called pursed lip breathing. They breathe in through the nose, but they blow out really slowly through tightly pursed lips. It looks like they're trying to blow out a candle through a tiny little straw.
It's an instinctual survival mechanism. Because their airways are floppy and have lost their structure, if they exhale too quickly, the negative pressure actually collapses the airway entirely, trapping even more air.
Oh, wow.
By blowing out slowly through a tiny opening, they create back pressure. We call it positive end expiratory pressure, or PEEP. This invisible pillar of pressurized air travels back down into the lungs and physically stents the floppy airways open just long enough to let the trapped carbon dioxide escape.
The body finds a way to hack its own broken machinery. It's incredible. But all of this chronic damage leads to a physiological adaptation that is, quite frankly, terrifying if you don't understand it.
You're talking about the oxygen paradox.
Yes. We need to talk about the oxygen paradox. This completely broke my mental model of how breathing works when I first read about it.
It is honestly the single most critical concept in respiratory medicine, and misunderstanding it kills patients every year.
Okay, let's trace this step by step. We established at the very beginning that in a normal, healthy person, the urge to breathe is driven by carbon dioxide.
Right. Central chemoreceptors in our brainstem monitor our blood pH. When CO2 rises, the blood gets slightly acidic, the brain hits the alarm, and we naturally take a breath. Oxygen levels barely factor into the minute-to-minute regulation of our breathing.
But a COPD patient has been failing to exhale properly for, like, a decade. They're constantly trapping CO2 in their lungs. So their baseline carbon dioxide levels in the blood are chronically sky high.
Exactly. So the CO2 alarm in their brain is essentially ringing 24/7.
Right.
And just like a person living next to a train track eventually stops hearing the trains, the brain's central chemoreceptors eventually become completely desensitized to carbon dioxide.
The brain basically says, the CO2 alarm is broken, I'm just shutting it off.
That's exactly what happens.
So what keeps them breathing then?
Yeah.
What tells their diaphragm to contract?
A backup system kicks in. The body shifts its primary respiratory drive to the peripheral chemoreceptors, which are located in the carotid arteries and the aortic arch.
And those receptors don't care about carbon dioxide at all, do they?
Not at all. They only measure oxygen. The COPD patient's entire subconscious drive to breathe shifts from I have too much CO2 to I have too little oxygen. This is called the hypoxic drive.
Hypoxia becomes the gas pedal, which sets up a lethal trap for a well-meaning bystander or maybe a new healthcare worker.
It's a huge trap.
Imagine you see a COPD patient struggling. They're blue around the lips, visibly gasping. Your absolute first instinct, and I mean this on a visceral human level, is to grab an oxygen mask, crank it up to 100% flow, and just flood their system with life-saving oxygen.
And if you do that, you wipe out their drive to breathe.
Wait, hold on. I really want to emphasize this for you listening. By giving them oxygen, I stop them from breathing.
Yes. If you flood a COPD patient's blood with high concentration oxygen, those peripheral chemoreceptors sense the massive influx of O2. The brain basically says, fantastic, the oxygen emergency is over. We have plenty of oxygen. You can stop working so hard.
Oh my God.
And the patient's respiratory rate will just plummet. They will take fewer, shallower breaths.
Which means they stop ventilating.
And because they stop ventilating, they stop blowing off carbon dioxide. Their CO2 levels, which, remember, were already dangerously high, will skyrocket to lethal levels.
And carbon dioxide acts as a narcotic at high levels, right?
It does. They will become confused, then lethargic. They will literally slip into a coma and their heart will stop. You can cause respiratory arrest by giving them too much oxygen.
That is absolutely wild.
Yeah.
It's totally counterintuitive. You basically have to keep them slightly starved of oxygen just to keep the engine running.
You have to keep them in what we call the Goldilocks zone. For a normal, healthy person, an oxygen saturation of 88% is a major medical emergency.
Right.
But for an advanced COPD patient, 88% to 92% is their safe, targeted baseline. You give them exactly enough oxygen to keep their organs alive, but not enough to turn off the alarm.
Wow. And as if managing the hypoxic drive isn't complicated enough, the damage from COPD doesn't stay confined to the lungs. It triggers a massive systemic failure in the cardiovascular system, too. The medical term is cor pulmonale.
Cor pulmonale translates to right-sided heart failure induced by a primary lung pathology.
So this goes back to our third pillar from earlier, perfusion. The right side of the heart has one specific job. It receives the dark, deoxygenated blood from the body, and it pumps it the very short distance into the lungs to pick up oxygen.
Normally, the lungs are a low-pressure, highly compliant system. It's a very easy pump for the right ventricle.
But an emphysemic lung is scarred, it's destroyed, and it's missing massive amounts of capillary beds.
Furthermore, the blood vessels in the lungs do something very strange when they are exposed to chronic hypoxia. They constrict.
Oh, so they clamp down.
Yes. So the right ventricle of the heart is no longer pumping into a soft, compliant sponge. It is trying to force blood into a high-pressure, constricted system. It's literally like trying to push water out of a fire hose that has a massive kink in it.
The pressure required to push the blood forward just skyrockets. This is pulmonary hypertension. And the right ventricle, which is normally a fairly thin, weak muscle, has to start working overtime.
And it acts like any muscle forced to lift heavy weights every single minute of every single day. It hypertrophies, it gets thicker and larger.
But in cardiology, larger does not mean better.
Definitely not. A thick, hypertrophied heart muscle becomes stiff, demanding way more oxygen than it can actually be supplied. Eventually, the muscle exhausts itself, stretches out, and fails.
When the right ventricle fails, it can no longer pump the blood forward into the lungs effectively. So the blood has nowhere to go but backward. It literally backs up into the venous system of the entire body.
The hydrostatic pressure in the veins increases, physically forcing fluid out of the blood vessels and into the surrounding tissues.
So the patient develops severe dependent edema. Their ankles, their calves, and their legs swell up with massive amounts of fluid.
If they are bedbound, the fluid pools in their sacral area. The fluid backs up into their liver, causing hepatomegaly, and leaks into their abdominal cavity, causing a SICE, which is a tight, swollen, fluid-filled belly.
It is just a devastating cascade. A lifetime of smoking destroys the alveoli, which causes pulmonary hypertension, which destroys the right side of the heart, which causes fluid to literally drown the lower half of the body.
It's all connected.
Because their entire system is working so hard, managing the daily life of a COPD patient requires incredibly specific interventions. Let's look at their diet, for example. You mentioned earlier that they are burning thousands of calories just breathing.
They are extremely hypermetabolic, so they need a high-calorie, high-protein diet to prevent their own muscles from wasting away.
But they physically cannot eat a large meal, can they?
No, they can't. If you eat a massive dinner, your stomach expands. In a healthy person, the diaphragm just easily pushes down against the stomach. But in a COPD patient, the diaphragm is already flat, weakened, and struggling for space.
Oh, right.
A full stomach physically blocks the lungs from expanding. So they must eat 5 or 6 very small, nutrient-dense meals a day.
And the actual macronutrient breakdown of those meals is deeply tied to their respiratory physiology, which I found fascinating. They're prescribed a low-carbohydrate diet. I didn't understand this at first, but it comes down to something called a respiratory quotient at the cellular level.
Yes, it's pure cellular chemistry. When your mitochondria metabolize glucose, which comes primarily from carbohydrates, the chemical reaction produces a massive amount of carbon dioxide as a byproduct.
Really? Just from digesting food?
Yep. Specifically, for every molecule of oxygen consumed to burn a carbohydrate, 1 molecule of CO2 is produced.
But when you metabolize fats or proteins, the ratio is much lower. You produce significantly less CO2.
Exactly. A high-carbohydrate diet literally manufactures more carbon dioxide gas that the lungs now have to figure out how to exhale.
Which is their main problem to begin with.
Right. For a patient who is already trapping lethal amounts of CO2, a huge plate of pasta is an internal respiratory burden.
It's a biological CO2 factory.
That is incredible.
Yeah.
Okay, we've explored the chronic, slow-motion collapse of COPD. I want to shift gears completely and look at what happens when the mechanical structure of the lungs fails acutely. Suddenly.
It's structural failures.
Right. There are 3 major structural failures we need to examine: pneumonia, atelectasis, and sleep apnea. Let's start with pneumonia. Pneumonia is a massive inflammatory response to an acute infection inside the lung tissue itself. It can be bacterial, viral, or even fungal.
So unlike asthma, which swells the tubes leading to the alveoli, pneumonia attacks the actual alveoli directly.
Yes. The immune system detects the bacteria, and it rushes white blood cells, proteins, and fluid to the site to fight the infection.
Which creates an exudate, right? A thick, purulent fluid made of dead bacteria, immune cells, and plasma. And this fluid literally fills up the microscopic air sacs.
We are right back to Fick's law of diffusion. The oxygen makes it all the way down the airway, but instead of finding a nice microscopic one-cell thick membrane to slip across, it hits a swamp of infected fluid.
Gross. And oxygen cannot diffuse effectively through a millimeter of pus. The blood rolls past the alveolus, but it doesn't pick up any oxygen.
When a physician or nurse listens to this patient's lungs with a stethoscope, they aren't going to hear the normal, clean, rushing sound of air. They will hear diminished sounds in the infected lobes.
And crackles, right?
More specifically, they will hear crackles, sometimes called rales.
Crackles are exactly what they sound like, I'm assuming.
It is the literal acoustic sound of air bubbling through the infected fluid, or the sound of sticky, fluid-filled alveoli popping open as the patient inhales. It sounds like rubbing strands of hair together right next to your ear.
That's a very vivid description.
Yeah.
And the body's obviously desperately trying to clear this fluid mechanically, which results in a violent, productive cough.
And assessing the sputum, the material they cough up, is a crucial diagnostic clue.
What are we looking for in the sputum?
Well, thick, green or yellow sputum implies a heavy immune response to bacteria. Sometimes the inflammation is so severe that the microscopic capillaries literally burst, mixing old, oxidized blood in with the mucus.
Oh, wow.
That creates a classic rusty brown colored sputum.
The first, most immediate intervention for a patient drowning in their own inflammatory fluid isn't even a drug, is it? It's literally just gravity. You position the patient in what's called high Fowler's.
High Fowler's position just means cranking the head of the hospital bed up to a 60 to 90 degree angle, basically sitting them straight up.
Because that forces the heavy organs of the abdomen, the liver, the stomach, the intestines, to drop downward into the pelvis.
Exactly. This clears the maximum amount of space for the diaphragm to drop down, giving the unaffected, healthy areas of the lungs the best possible chance to fully expand and compensate for the infected lobes.
So pneumonia is fundamentally a fluid problem. Let's look at the second acute structural failure, which is a pressure problem. Atelectasis.
Atelectasis is the mechanical collapse of the alveoli. It isn't necessarily filled with fluid. The walls of the air sacs simply stick together and deflate.
Like a balloon that's had all the air sucked out of it.
That's exactly it.
And this is notoriously common in surgical wards, right?
It is the most common post-operative respiratory complication. Think about the entire surgical process. First, we sedate the patient, which depresses the central respiratory drive in the brain. They breathe very shallowly. Then, we cut them open. If they have abdominal or chest surgery, the physical act of taking a deep breath stretches those fresh incisions, causing severe pain.
So they instinctively splint their breathing. They take tiny, shallow, painless breaths to avoid hurting themselves, and they lie flat in bed for 2 or 3 days.
And because they aren't taking deep, expansive breaths, the alveoli at the very bases of the lungs are never fully inflated. Without that constant stretching and the normal distribution of surfactant, the walls just stick together. They collapse.
And once they collapse, they participate in zero gas exchange. If enough of them collapse, the patient develops a low-grade fever and hypoxia.
To fix this, we rely on mechanical intervention. The patient has to generate massive transpulmonary pressure to physically rip those wet balloons back open from the inside.
And we guide them using a little piece of plastic called an incentive spirometer.
It is a totally simple, cheap, incredibly effective device. It's just a clear plastic chamber with a mouthpiece and a little piston or a ball inside. The goal is to raise the piston to a targeted volume.
But the way people use it is almost universally wrong at first glance. I mean, if you hand someone a tube with a ball in it, their instinct is to blow into it as hard as they can, like blowing up a balloon or using a party favor.
Which is the exact opposite of what you want to do. Blowing out empties the lungs.
The patient actually has to seal their lips around the mouthpiece and suck in. They have to take a slow, deep, powerful inhalation to pull the piston up.
They are using the negative pressure of their own diaphragm to pull the lungs open from the inside.
And once they pull it up to the target volume, we are back to the rule of tens from earlier.
Yes. They must hold that deep breath for as long as possible, ideally up to 10 seconds. Holding the breath at maximum inhalation forces the air pressure deep into the bases of the lungs, physically stenting those collapsed alveoli open.
Is a mandatory exercise in the hospital. And nurses will literally wake patients up to make them do 10 repetitions every single hour.
It's that important.
The third structural failure happens much higher up in the respiratory tract. We've talked about microscopic alveoli failing. Sleep apnea is a macroscopic mechanical failure.
Obstructive sleep apnea is a physical collapse of the upper airway, specifically the pharynx.
When we are awake, the muscles of our throat actively hold the airway open. But when we sleep, all skeletal muscles relax. In a patient with sleep apnea, the physical weight of the soft tissue in the neck, which is often, though not exclusively, correlated with obesity, presses down on the relaxed airway.
When the patient lies supine, or flat on their back, gravity pulls that heavy, relaxed tissue backward. The tongue falls back, the soft palate drops, and the airway is literally crushed shut.
The patient is asleep, their chest is trying to heave, but the door is completely barricaded. They stop breathing. This is the definition of hypoventilation.
And we know the chemical math of hypoventilation. Oxygen levels plummet, and carbon dioxide levels surge.
The brain, monitoring that blood chemistry, realizes it is suffocating. It triggers a massive sympathetic nervous system spike. An adrenaline surge jolts the brain awake.
Not fully awake to consciousness, though. Just enough to regain muscle tone in the throat.
And the patient will take a massive, gasping snort or choke, pull in a few rapid breaths to clear the CO2, fall back into deep sleep, the muscles relax again, and the airway is crushed shut again.
The cycle can repeat 30, 40, or even 100 times an hour.
100 times an hour, that's insane.
It's extremely taxing on the body. The immediate symptom is exhaustion. The partner notices the apocalyptic snoring, and the patient wakes up feeling like they haven't slept at all.
They have profound daytime sleepiness and often severe morning headaches because that trapped carbon dioxide dilates the blood vessels in the brain. But the hidden long-term danger is actually cardiac, isn't it?
Think about what is happening to the cardiovascular system. Every 2 minutes, the brain thinks it is dying. It dumps adrenaline into the bloodstream, spiking the heart rate and blood pressure, completely depriving the body of the parasympathetic rest and digest healing phase of sleep.
Years of this chronic, nightly hypoxia and hypersympathetic stress just destroy the vascular system. It leads directly to chronic hypertension, heart failure, arrhythmias like atrial fibrillation, and significantly increases the risk of a massive stroke or sudden cardiac death.
Because the problem is purely mechanical, the gold standard solution is also purely mechanical. A CPAP machine, which stands for continuous positive airway pressure.
The patient wears a tightly sealed mask over their nose, or nose and mouth.
Oh.
And the machine functions basically as an air compressor. It blows a continuous, high-pressure stream of room air down the back of the throat.
It acts as an invisible pneumatic splint. The sheer pressure of the air forces the soft tissue of the throat out of the way, keeping the airway physically propped open so the patient can breathe normally all night long.
It's all physics. Whether it's the microphysics of fluid blocking diffusion in pneumonia or the macrophysics of a collapsing throat. So we've walked through the mechanics of breathing, the alarm bells of hypoxia, and the diseases that break the system. Let's move into the final phase of this deep dive: diagnostics and interventions.
Right. How do we actually measure the invisible oxygen in a patient's blood without constantly drawing vials of it?
We use a absolute marvel of modern biomedical engineering, the pulse oximeter, or a PO2 monitor. It allows us to non-invasively measure the percentage of hemoglobin binding sites that are currently saturated with oxygen.
It looks so simple. It's just a little plastic clip that goes on the end of a patient's finger. But the physics inside that clip are brilliant. It relies on spectrophotometry.
Spectrophotometry, that's a mouthful. How does it work?
The clip has two sides. One side emits two very specific wavelengths of light, red light and infrared light. The other side has a photodetector that catches whatever light actually makes it all the way through the finger.
And the magic lies in how blood absorbs light, right?
Yeah.
Oxygenated blood, so hemoglobin that is fully loaded with O2 is bright red. It absorbs infrared light but lets red light pass through.
Exactly. While deoxygenated blood is a darker purplish color, it absorbs red light and lets the infrared pass through. The machine's microprocessor constantly compares the ratio of absorbed red to infrared light and uses a complex algorithm to spit out a percentage.
So a reading of 98% literally means 98 out of 100 hemoglobin seats have oxygen in them.
Yes, it is instantaneous, painless, and vital. But it has massive, dangerous blind spots because it fundamentally relies on light physically passing through a pulsing capillary bed.
Right. If anything distorts that capillary bed or that light, the machine will just lie to you.
Let's run through the things that can trick the machine. The most common is poor peripheral perfusion.
Like if someone is just cold.
If the patient is incredibly cold or if they are in shock, their body instinctively clamps down the blood vessels in their extremities to keep the warm blood in the vital organs, like the heart and brain.
So the fingers become cold and vasoconstricted. There isn't enough pulsing blood for the machine to read, and it will just drop out or give a falsely low reading.
Edema ruins the reading too. If the patient has heart failure and their hands are swollen with fluid, the light scatters through the water and can't read the hemoglobin accurately.
Motion artifact is another huge one,
Yeah.
right? Like if the patient is shivering or if they're having those severe tremors from an albuterol treatment we talked about. The physical shaking disrupts the sensor's ability to lock onto the pulse wave.
And something as simple as dark nail polish or artificial acrylic nails can completely block the light diode.
That is wild to me. So you have to take off their nail polish?
Sometimes, yes. Or use an earlobe probe instead. And then there's the terrifying false positive of carbon monoxide poisoning.
Oh, this is a critical distinction. Carbon monoxide binds to the exact same iron seats on the hemoglobin molecule that oxygen does, right?
Mm.
But it binds like 200 times more tightly.
Yes, and the pulse oximeter isn't smart enough to know what molecule is actually in the seat. It just sees that the seat is full and the blood is bright red.
So a patient literally dying of carbon monoxide poisoning will have an SpO2 reading of 100%.
They will. This all circles back to the most fundamental rule of clinical medicine. Treat the patient, not the machine.
I love that rule. So if the pulse oximeter suddenly alarms and says the patient's oxygen is 72%, you don't immediately initiate emergency protocols. You look at the patient first.
Exactly. If they're sitting up in bed, eating a sandwich, having a perfectly normal conversation, and their skin is pink, the machine is wrong. The probe slipped off or their hand is cold.
Conversely, if the machine says 99%, but the patient is thrashing wildly in bed, tearing at their gown, sweating profusely, and displaying profound restlessness, you don't trust the machine. You trust your clinical assessment.
The brain is screaming for a reason. You assume hypoxia and investigate immediately.
And if you determine they truly need supplemental oxygen, you have to choose the right delivery hardware. Because oxygen is a prescription drug, it has precise dosages and flow rates.
The baseline, most ubiquitous tool is the nasal cannula. It's that lightweight green tubing with two little prongs that sit just inside the nostrils.
It can deliver a low flow of oxygen, usually between 1 to 6 liters per minute, which bumps the inspired oxygen concentration up from room air's 21% to maybe 44%.
But there is a remarkably common mechanical error that healthcare workers and patients make constantly with the nasal cannula.
Putting it in upside down.
Yes. The two prongs are naturally curved. The natural anatomy of the nasal passage curves downward toward the pharynx. The prongs must be pointed downward.
But people constantly put them in upside down. They point the curve up toward the ceiling, which means the concentrated oxygen stream is just blasting the roof of the nasal cavity and the frontal sinuses.
It dries out the mucosa, causes severe nosebleeds, and honestly doesn't actually reach the lungs effectively at all.
If a patient needs more oxygen than a cannula can provide, we step up to masks, right? A simple face mask covers the nose and mouth. But for severe emergencies, we use a non-rebreather mask.
This is the mask you always see in medical dramas. It has a heavy plastic bag hanging off the bottom of it.
That bag is an oxygen reservoir. It must be inflated with pure oxygen before you even put it on the patient's face.
The mask also has one-way flutter valves on the side. When the patient inhales, they draw 100% pure oxygen from the bag. When they exhale, the flutter valves open, letting the carbon dioxide escape into the room while preventing room air from diluting the next breath.
It is basically a brute force method to maximize oxygen delivery during trauma or severe hypoxia.
But wait, a brute force delivery of pure oxygen is exactly what we established earlier will kill a COPD patient. So how do we give them a precise dose without turning off their hypoxic drive?
We use a brilliantly engineered device called a Venturi mask.
The Venturi mask doesn't rely on guesswork. It utilizes the Bernoulli principle of fluid dynamics.
More physics. It has specific color-coded plastic adapters that snap into the base of the mask. Each adapter is precisely calibrated with a specific sized aperture.
Right. As the pure oxygen from the wall rushes through that tiny aperture, it creates a high-velocity jet. This jet creates a localized pressure drop, which physically acts as a vacuum, sucking in a highly precise mathematical ratio of ambient room air through open ports on the side.
It mixes pure oxygen with room air perfectly. So regardless of how fast or how deep the terrified COPD patient is breathing, The mask guarantees they will inhale exactly 24% or 28% or 32% oxygen. No more, no less.
It dials them perfectly into that safe Goldilocks zone.
It is a perfect synthesis of applied physics managing a delicate biological paradox.
It really is.
This entire system is just staggering when you zoom out.
Yeah.
We've traced the path from the macromechanics of the diaphragm pulling a vacuum down to the microphysics of surfactant keeping wet balloons from collapsing.
We've seen how the hemoglobin trucks load up the oxygen and how vital it is that the ventilation perfectly matches the perfusion.
We've explored what happens when the smooth muscle spasms in asthma, or when decades of damage destroy the elastic recoil in COPD, forcing the brain to completely rewire its own respiratory drive.
We looked at the sheer mechanical obstructions of fluid in pneumonia, collapsed sacs in atelectasis, and a collapsing throat in sleep apnea.
And we explored how we measure all of this with the physics of light and treat it with the physics of air entrainment.
It is a continuous, invisible miracle of balance.
Every single cell in your body, from the neurons in your brain to the muscle fibers in your toes, is completely dependent on this exact sequence of events occurring flawlessly 20,000 times a day.
I will leave you with a final thought to mull over, connecting this immense physiology to your everyday life. We established earlier that the brain's very first, most sensitive reaction to even a fractional drop in oxygen delivery is a profound sense of restlessness, irritability, and anxiety. How many unexplained moments of panic, sudden brain fog, or midday irritability in our modern lives might simply be the result of poor gas exchange? Consider how we sit. Slouched over keyboards, compressing our diaphragms, taking shallow upper chest breaths, and functionally hypoventilating for hours on end without realizing it.
Wow. So before you assume you are having a terrible day or that your stress is purely psychological, well, maybe your brain is just ringing the alarm. Maybe you just need to sit up, drop your diaphragm, and open the warehouse doors. Thank you for joining us on this deep dive. Go ahead and take a deep, perfectly ventilated breath.